I'm Mattia Perrone. I'm a research scientist at Rush University Medical Center here in Chicago. And today I'll talk about how to teach vision language models to read spine MRIs. So let's start with some motivation. Why do we want to build a model that is able to read spine MRIs? So basically to generate radiology reports starting from medical imaging. I think the number here on the left-hand side of the slide is pretty self-explanatory. According to the literature, these data were about from 2 years ago. 54% of radiologists experience active clinical burnout. There has been an increase in terms of volume for medical imaging, over 100% the last decade. And also I would say that spine is particularly suitable for in terms of vision language models. First of all, because there's high volume, and then because the reports are pretty structured by the different spinal levels, but I'll talk about it later a bit more in depth. Okay, so that's the dataset that we have, and the dataset that I used to obtain the results that I'll be talking about today. I want to clarify that this is like a preliminary, it's a pilot study with some preliminary findings. We are currently working on this dataset to, improve the framework that we have, but I'll show the results that we have today. So we have around 5,000 patients, a bit less, from one institution, Rush Medical Center, and we are just using not the full MRI. If you're familiar with MRI, it basically consists in a stack of 2D slices. We're using 5 sagittal slices, so 5 slices instead of the full volume, which is more or less about 20, 25, depending on the scanner that you're using. Some details also about the cohort that we're using. I want to focus in particular on the anatomical scope here. So we want to understand what's going on in the spine, if there are any pathologies, but we're just focusing on 2 spinal levels, which are L4, L5, and L5, S1, so not the full lumbar spine. Why are we doing that? First of all, because it's easier if we focus just on 2 instead of on the full spine, which has 5, the lumbar spine. But why are we picking L4, L5, and L5, S1? Basically because these are the ones where usually more pathologies occur. Low back pain usually occurs at these 2 levels, and also these levels are the ones with the highest loads. So we're in particular focusing on 5 spinal pathologies right now: disc herniation, bulging, central canal stenosis, spondylolisthesis, and fracture. But we're planning, of course, to expand also to other pathologies. So as I was saying, this is the dataset that we have right now, but we are currently expanding the framework. And so our target dataset includes 20,000 patients. We actually already have these 20,000 patients, and we are acquiring more. We have these data from 2 different institutions, so not just Rush, but also Midwest Orthopedics at Rush. And also, for the current project, we are working on the full 3D volume, so not just 5 slices, including both sagittal and axial MRI. So don't want to go too much into a detail, but the idea is that the orientation of the slices is different, and this can help to spot different pathologies if we have both sagittal and axial. Okay, so that's the pipeline that we've implemented. We have the input, which is the MRI. So here I just put 1 slice. You would have to imagine the full volume. We did some pre-processing on the MRI, so some resampling, cropping, padding, and the selection of the 5 slices that I was talking about before. And then we have the model, the vision language model, that actually generate the reports. So for the model, we use the Quen 2.5 vision language. So this study is more or less was done 1 year, a bit more ago. So Quen 2.5 was the latest model available. Right now, of course, there are other models. I think the latest is 3.7 or 3.8, but at the time it was the latest one. So for the vision encoder, we are fine-tuning using LoRa adapters, while language decoder is frozen. And then basically the model is able to generate the reports. We are focusing, as I was saying before, at L4, L5, and L5, S1. A couple of justifications of the choices that we made. So why did we choose Quen? First of all, I already talked about the version 2.5 because it was the latest available. But why did we choose Quen instead of maybe other models such as Lab or maybe Mistral, which were also vision language models? So as I was saying before, we wanted to give multiple slices, multiple images basically, which are slices of the MRI as input. And Quen was basically, I would say, the only model, one of the few that allowed to do that. Just to clarify, why did we want to give multiple images as the input and not just one image from the MRI? Because you need multiple images from the MRI to spot the different pathologies. If you give just one image, maybe it could be that the pathology is located in another part of the spine, and so you're not able to locate it. Then the other thing is about the version, like we chose Quen 2.57 billion, since it fits a single A5000 for GPU. Of course, we have like bigger GPUs, but we wanted to start small, both because this, as I was saying, a pilot study, and also because we don't have a huge number of samples. We have around 5,000 patients, and so we don't want to occur in overfitting. Then another important thing is that why did we use LoRA instead of full fine-tuning? I would say mostly for the same reason. So not that many patients, and so LoRA is more suitable, especially if you have like a small data set, and also far cheaper, like less computational intensive. Okay, so I would like also to talk a bit more about the pre-processing, in this case on the text side, talking about these structured radiology reports. So when you get a radiology report, like from a radiologist, this is what it looks like. It's like free text. And I don't want, again, to go into detail on the clinical side, but here I just focused on the L4, L5, and L5S1, so the two spinal levels I was talking about before. And we basically implemented a pipeline to pre-process these reports. So first of all, we de-identify the reports. This is already, of course, de-identified. And then we gave the report as input to GPT-4, just the API, so that it could generate a structured report and normalize by spinal level, as you can see here on the right-hand side. And we also extracted the pathologies at the different spinal levels. So you can see basically, like the pathologies here underlined are the same that we have here in the pre-processed report. Again, we are just focusing on the 5 pathologies that I was mentioning before in one of the first slides, but now we are also expanding to other ones. And then we also performed a manual validation of 100 full reports. I didn't include the results. Basically, we wanted to ensure that all the pathologies in the free text are also included in the pre-process. Like we don't want, of course, GPT-4 to hallucinate or to skip any pathologies. The performance was pretty good. I think the F1 score was around 0.97, 0.98. And so basically that's the whole pipeline, like from the radiology report free text to the structured radiology report. Why do we want to do that? There are 2 main reasons. The first one is that we want to be able to basically assess the report that is generated by the model. And to do that, we need some, like clinical metric. The idea is basically to extract the pathologies from the report and then use some kind of classification metrics, maybe the F1 score, but it's way easier to extract pathologies if we have a pre-processed, a structured report, like this one on the right-hand side, rather than free text. You can even use like a regex or maybe an LLM even locally to do that, but it's way more complicated if you have free text. And the other thing is that it's also easier for the model to learn what's going on, like to generate these kind of reports, structured reports, instead of generate like free text. Because here, all the information, it's well organized. You have first spinal level, then the pathology, the severity of the pathology, while here it's way more complicated. And so it's more difficult like to understand and to basically generate the prediction. So here, just wanted to give a very brief example of a radiology report that's written by radiologists, and then one that's generated by the model. And also to clarify better, like this metric that we are using to assess the report, one of the metrics that we're using. As I was saying, just an F1 score, it's more a matter of implementing the pipeline and then extracting the pathology. So true positives, false positives, false negatives, and true positives, false positives, false negatives, and true negatives. And then we are just, basically computing the classic, F1 score. For example, if we focus on the first level, for F5, we have, that both the radiologist and the model found out that there's listhesis. And same thing for stenosis. You can see stenosis here and also spinal canal stenosis here. So we have 2 true positives. while for the L5S1, the other level, the radiologist reported a specific pathology, which is disc bulging here, while for the generated report, the model thought that it was disc herniation. So we have a false positive and a false negative. And basically, you can just compute, precision, recall, and F1 score. And so we get, this final metric pathology F1, which can give some information in terms of on the clinical side, I would say. So now I'll show some results, again, preliminary results of this first part of the study. We have some metrics here in blue, which are from, I would say, NLG metrics, so from natural language generation. We have rouge, which is for lexical overlap between the radiology reports, written by the radiologist, and the prediction from the model. Bird score, which is for semantic similarity. And then we have the pathology F1, which is the one that we actually implemented. One thing that I want to clarify is pretty important. Here, we didn't include any assessment by the actual radiologists. And we didn't include any kind of blind, assessment of the radiologist. Maybe just give the report to the radiologist and ask, if this was generated by AI or if it's a real report. Because again, we're just in the first part of the study, but that's something for sure that we are planning to do. Because of course, radiologists are in the end the users of these kind of models, which the model would help them to basically work faster, I would say. And so that's something that for sure we are planning to do. So if we compare with baselines, so if we compare this Quen 2.5 model with zero-shot Quen, so that hasn't been fine-tuned, and GPT-4 Turbo, again, we use this model because this was more than 1 year ago, we see better performance for all these metrics. The F1 score nearly doubles if we compare zero-shot Quen with this fine-tuned Quen. But if you compare the other side with some other studies in the literature, we see that the performance are lower. So one thing, again, that I want to clarify is that this is just to give a general idea of the landscape, of the fact that there are other studies working on this topic, but it's a more a qualitative, I would say, assessment. First of all, because I'm just putting in the same table studies that are dealing with different anatomies. There's brain, chest, spine, and also different modalities, because there's MRI, X-ray, and CT. Also, this clinical F1 metric is not always defined this way, in the same way. I showed before the way we calculate this pathology F1 score, but different studies may use different definitions. So that's just to give a general idea of the fact that there are other studies in the field, also doing other working on other anatomies and other modalities. But for sure, there's plenty of room for improvement for us. So why are we getting these results? How can we improve? We believe there are mainly two reasons. The first one is about the data. We have just 5,000 patients, and basically, even if we are using LoRA, which the whole point to using LoRA is also to prevent overfitting, we're still seeing overfitting because probably of the low amount of data. We also try to maybe diminish the LoRA rank or unfreeze less layers, apply LoRA to less layers, but we're still seeing overfitting, or maybe sometimes we see bias if we diminish to less. So we think it's for sure a data problem. But another important thing is that when using Quen, in the pre-trained version, so before we do any kind of fine-tuning, it has basically never seen any kind of spine MRIs like the model that it's you can just import the open source. And so that's also something for sure to keep in mind. So if we distinguish between the vision component and the text component, the text decoder, we believe that the bottleneck is mostly on the vision side, especially on the fact that the pre-trained version has not seen any kind of spine MRIs, any kind of data similar to ours. In fact, we don't think there's any limitation on the text side, since basically the NLG metrics, the natural language generation metrics, such as rouge and bird score, were pretty good. So what's next? The idea is that we don't think that actually more fine-tuning would really help. But since we have these 20,000 unlabeled volumes, basically this could be very useful for another approach, such as self-supervised learning. So the idea is to shift from vision language models to a foundation model. And there are, I would say, already some examples in the literature of self-supervised learning studies that are in medical imaging. These are the three most common, I would say, frameworks that are used. So there's, some masked modeling, especially, with masked autoencoders to reconstruct basically images. There's some contrastive learning, especially I would say in terms of image text, especially important I would say in medical imaging to promote the alignment between the MRIs or the CTs, anyway the imaging side and the reports. And then there's also some self-distillation, such as student-teacher frameworks, such as for example Dino. As I was saying before, there are some interesting studies, different anatomies also from the eye to chest, but I wanted to focus in particular on these two, which were actually published few months ago, SpineAgent just a few weeks ago, and I want to focus on these ones because they're still foundation models, as I'm going to show in this slide, but report generation is one of the downstream tasks that they evaluated. So the idea is that our goal is still the same. We still want to teach basically this model AI to how to read spine MRIs, but that's just the framework has shifted because now the idea is that leveraging the amount of data we have, we want to create at first a vision backbone using self-supervised learning, and then test it on different downstream tasks. And of course, one of the main downstream tasks still remain radiology report generation. If we go through quickly these two studies, we have Merlin from Stanford, released again a few months ago, 15,000 CTs. In terms of the pre-training strategy, they did also some kind of weak supervision using the billing code. So it's some kind of classification, but I want to focus a bit more on the second part, which is the self-supervised learning side, on the contrastive learning approach, clip style, especially for the alignment between the text encoder and the vision encoder. So again, don't want to go too much into detail about the architecture, but they do have just two components as the encoder, just to promote the alignment, but then during training, but at the inference, they just keep the vision encoder, so that and then basically they evaluate the backbone on the different downstream tasks, and when they do the report generation, they just basically attach, let's say, a text decoder so that the text can be actually generated. And then we have SpineAgent. That's also actually pretty interesting because it's pretty similar to what we're doing. It's spine MRI, around 30,000 patients. They're using two strategies for self-supervised learning. There's both Dino V3, so it's a self-distillation approach, and then again the use of radiology reports for this clip style alignment again between the radiology reports and the MRIs. And of course, downstream task where report generation is still, I would say, the core of the study. So the idea is to build the vision backbone first, and then test on different tasks, such as, of course, report generation. Okay, so if we just sum up, what we have done was at first to implement the vision language model framework, Quen 2.5, vision language, just using LoRA on the vision component, and then keeping the language decoder frozen. We saw that the model was performing better than baselines, so the fine-tuning was actually working, but of course there's a lot of room for improvement. So that's why we shifted to another framework, the self-supervised learning approach. The good thing is that there are no labels needed. And of course, we want to anyway go a bit further, respect to the studies that I just showed in literature. So we are, assessing few experiments to do. For example, we want to benchmark on different self-supervised learning families on a shared vision transformer backbone, which means that I showed in one of the previous slides that there are different frameworks that can be used in self-supervised learning. There's Dino, there's a masked encoder, there's contrastive learning, the clip style. But there are no studies showing on the same data and on using the same backbone, same model, if there's one of these families that performs better than other. And I would say this is especially interesting on spine, since spine has a pretty unique structure. Like there's a repetition of the same units like vertebrae and discs, and so it could be that some families maybe are more like work better than others. So that's for sure what something that we're trying to do. Another thing that we're trying to do is to test how much data are needed for the backbone. I was mentioning right now that we have 20,000 patients. We are acquiring more. And it would be interesting to see, what's the importance, for example, of radiology reports. Like if we're doing pre-training, maybe with eclipse style alignment, is like maybe having 20,000 patients plus the reports equivalent of having 40,000 patients without the reports, or maybe is there like some kind of amount or a threshold, let's say, that if we overcome, like there's saturation, so maybe, having that much data actually that doesn't really matter because you need data from another institution where, there are different parameters in terms of the MRIs or different scanners or things like this. So we are for sure like trying to do something related to that. We are also performing some like health checks, I would say, just on the backbone before going to the downstream tasks, such as scan, probe, rank, mean, frozen evaluation. Don't think I have like time to go into detail for the three of them, but of course, if you have questions, feel free to ask me. And then, the next step would be the downstream tasks. So basically test the backbone on different tasks, such as classification, segmentation, and of course, radiology report generation, because this still remains, the core of the study. Yeah, so that's it. Thank you for your attention. If you have any questions, happy to answer.